Today, we are jumping into one of the most critical areas in maternal health, the early onset of labor. We're going to break down preterm labor, or PTL, and pre-labor rupture of membranes, also known as PROM. My goal is to give you everything you need to know, not just for your exams, but for providing safe, confident care to your future patients.
Okay, let's get right into it with a scenario you will absolutely encounter. You get a call from your 32-week patient. She tells you she's got cramps and a backache that won't go away. Now that might sound kind of vague, right? But these are the classic, subtle signs that should immediately get your critical thinking gears turning. This is exactly where your sharp assessment skills come into play, and that's what we're going to focus on today. So here's how we're going to walk through this. We'll start with the initial alert, then move into recognizing the risks and signs. After that, we'll talk about confirming the diagnosis, then lay out the nursing intervention plan, and finally, wrap up with a super important piece on complications and patient education. Let's do it. All right, Section 1, the early labor alert. Before we can do anything else, we have to get our definitions down cold. Everything we're going to talk about is built on this foundation. First up, preterm labor, or PTL. The key thing to remember here is that it's not just one thing. It's two things happening together. You've got uterine contractions and you've got cervical changes. And the timing is everything. This has to be happening between 20 weeks and 36 weeks and 6 days of gestation. That specific window is absolutely crucial. Now, you should know that preterm isn't just one big category. We break it down by risk. So a very preterm baby, born before 32 weeks, is facing the highest level of risk. Compare that to a late preterm baby, born closer to 37 weeks. Their risk is lower, but it's still significant. The big takeaway here is simple. The earlier the gestational age, the higher the risk for that newborn. Next up is PROM, pre-labor rupture of membranes. This is just what it sounds like. The water breaks before true labor actually begins. Now, if this happens before 37 weeks, we call it PROM. That P stands for preterm. But honestly, in either case, once that protective amniotic sac is broken, our number one enemy, the single biggest risk we're fighting against, is infection. Okay, let's move into Section 2, recognizing risks and signs. I mean, knowing the definitions is great, but being able to spot the risks and the signs in a real-life patient, that's where you as a nurse become a lifesaver. Your first and maybe most powerful tool is a really thorough patient history. The risk factors for preterm labor are all over the map. They can be medical, like an underlying infection. Even something as common as a UTI can trigger uterine irritability. It could be a history of a previous preterm birth, or it could be social factors like a lack of prenatal care or even domestic violence. Your job is to be the detective connecting all these dots. And we love a good mnemonic to help this stuff stick, especially for the NCLEX. So, to lock in those major risk factors, just remember, I'm slow. I is for infection. M is for multifetal pregnancy. S is for smoking or substance use. L for lack of prenatal care. O for those age extremes, older or young, and W for low pre-pregnancy weight. This is going to be a huge help when you need to recall these fast. So what are you actually looking for? Well, your patient might not come in and say, I'm having regular, frequent uterine contractions. They're more likely to say things like, it just feels like my period is about to start, or I have this awful backache that won't quit. You have to be able to translate what they're feeling into these clinical findings. And of course, if they report any gush or even a small trickle of fluid, that's a major sign you need to investigate right away. All right, Section 3, confirming the diagnosis. So, your assessment has raised a big red flag. Your nursing intuition is tingling. Now you need the hard data, the objective proof from labs and tests to confirm what you suspect. Here's a look at our main diagnostic tools. There's the fetal fibronectin test, or FFN, which is a great predictor of who is, and just as importantly, who isn't, at immediate risk for delivery. We can use an ultrasound to measure the cervical length. The shorter it is, the higher the risk. And to see if her water is broken, we've got low-tech but super effective tools like the nitrazine paper test, which checks pH, and the Ferning test. And of course, we're always going to run cultures and a CBC to hunt for any underlying infection.
Okay, time for a quick knowledge check. Let's see what you've got. A nurse is caring for a client in preterm labor. Which of these are risk factors? You can select all that apply. A, UTI, B, multifetal pregnancy, C, maternal age under 20, D, substance use, and E, uterine abnormalities. Think about that I'm slow mnemonic. And the answer is, yep, all of them. Every single one of those is a known, established risk factor for preterm labor. Being able to recognize all of them is a huge part of a solid nursing assessment. Awesome job.
Let's move on to Section 4, the Nursing Intervention Plan. So, we've confirmed the diagnosis. What are we going to do about it? Our big goal here is to try and stop or at least slow down labor, to buy that baby as much time as possible to keep developing.
So before we even think about medications, we start with these foundational nursing actions. This includes things like modified bed rest, getting the patient on her left side to get the best possible blood flow to the placenta, and making sure she's super hydrated, because dehydration can actually increase uterine activity. All while you're keeping a close eye on her vitals for any sign of infection, and of course, continuously monitoring the baby. These are your immediate, first-line actions.
Now let's talk meds. First step is a tocolytic called nifedipine. It's a calcium channel blocker. Basically, it works by blocking calcium from entering the uterine muscle cells, which helps the uterus to relax. Your biggest job as the nurse is to watch for hypotension. That's a drop in blood pressure. So if your patient gets dizzy or has a headache, you need to check her BP. And here's the critical safety tip. If her blood pressure is already low, you absolutely hold the dose and call the provider. Next, we have the powerhouse of Tocolytics, magnesium sulfate. This stuff is a big deal. It acts as a CNS depressant to relax the uterus, but it also has this amazing side benefit. It provides neuroprotection for the baby's brain if they're less than 32 weeks. But, and this is a huge but, it is a high-alert medication. You have to monitor for signs of toxicity like a hawk. And you must always have the antidote, calcium gluconate, right there at the bedside. And speaking of toxicity, here's the one safety mnemonic you need to tattoo on your brain: burp. This is your checklist for mag sulfate. B for blood pressure that's dangerously low. U for urine output that's dropped below 30 milliliters an hour. R for respirations under 12, that's a massive red flag. And P for patellar reflexes being absent. If you see any sign of burp, you stop the infusion and call for help immediately.
Okay, let's test that right now. Your patient is on a mag sulfate drip. Which one of these findings screams toxicity? Is it A, urinary output of 45 milliliters per hour, B, respirations of 10 per minute, C, patellar reflexes are present, or D, a blood pressure of 118/70?
You got it. The answer is B, respirations of 10 per minute. A respiratory rate less than 12 is a classic, critical sign of magnesium toxicity. All those other values are totally fine. This is exactly the kind of question you can expect to see on the NCLEX.
So while we're trying to stop labor, we're also planning for the what if. What if the baby is born early? That's where betamethasone comes in. It's a corticosteroid we give to the mom. It crosses the placenta and helps speed up the development of the baby's lungs by boosting surfactant production. It's given as 2 injections 24 hours apart. And a huge NCLEX tip, this can raise the mother's blood sugar, so if she has diabetes, you'll need to be extra vigilant with her glucose monitoring.
Okay, we're at our last section, the safeguard. This is all about knowing the potential complications and, just as importantly, empowering our patients with the education they need to keep themselves and their babies safe.
When a patient's water breaks early, the risks are no joke. We're talking about things like chorioamnionitis, which is that serious intrauterine infection. We're also worried about the placenta separating, a prolapsed cord, or the baby's lungs not developing properly. These are all life-threatening complications that we have to be ready for.
Now, if a patient with ruptured membranes is stable enough to go home, your discharge teaching has to be perfect. They need to understand things like sticking to bed rest, doing daily fetal kick counts to monitor the baby's well-being, and checking their temperature constantly to watch for infection. And it's an absolute rule: nothing in the vagina. No intercourse, no tampons, nothing. They need to know exactly what signs mean. Come back to the hospital right now.
So we'll end on this thought. We've gone over all the science, the risks, the interventions, but I want you to think about this question. For a family, facing the possibility of a preterm birth is one of the scariest things they'll ever go through. Beyond all the tasks and the charting, the calm reassurance and compassionate support you provide, that's just as healing as any medicine. And that, right there, is what makes a phenomenal nurse. Thanks for tuning in.